All right, I think we're live. We're starting a little early today. We won't start our official segment till 3 o'clock, right, Sako?
Yes, sir.
We're playing some music now. I want to be DJ Dr. K for now. And if anyone is on, just say hello. Hi, everybody. I'm here having a little decaf coffee. And as you can see, this is my team, Cowboys. So let's give it up for the Cowboys. There you go. All right, hang on. We're telling more followers to join your video. Okay, so we're live on Instagram, Facebook, and YouTube.
All right, we got some people on Instagram.
Very good. All right. Okay. Play some music so everyone gets on. We got 3 minutes. 3 minutes.
We got more people.
I can play any song if you guys want to join me. So we start our official segment, and we're going to be seriously talking about foot and ankle conditions, surgeries. Hello, everybody. We're getting ready to go live. Well, we're live, actually. So let's see. What am I going to play? Ooh. This is another good song. I'm playing songs from my workout playlist. So these are all the songs that I play every morning when I do my cardio, and then in the afternoon when I do my weights. So I said, let's play some music before we get started. Because sometimes, hello everybody. Hi Fadi, Nexa, Onga, Adam, Frank, Cody. Very good.
Another one.
Nice. Good job, everybody. Thank you so much for logging in, guys. These sessions are really good. I love them. All right, this is actually one of my favorite songs lately. I'm sure you guys have heard it. It's everywhere, right? Tiesto is our guy. And Cowboys, by the way. They had a very bad game Sunday. Me and my boy were like so upset. Oh gosh. But you know what I always say? A good team should have a very bad game during the season so they can get their shit together. You have to have a bad game so you can go back to your drawing boards and say, you know what did not work? What didn't we do? What happened? You don't want that game to be your playoff, your playoffs game, because you're out. So I'm glad it happened to them. 6-1. It's happening to many teams. Green Bay lost their second game. Rams lost their second game. Brady lost his second game. So except Cardinals, they're still on top, 8-1. All right, we're gonna go to our live Q&A session in about a minute. We're getting everything ready, playing some music for you guys. But hi, Chica Marks, Sarah Diva. Oh, she's here. Thank you for joining in. Why are you there? Hi. All right, there we go. 3 o'clock. I'm gonna turn down the music, and we're gonna get serious now. Maybe one day I DJ for you guys. You never know. I used to DJ. I still have my DJ equipment, actually. All right, everyone. Well, thanks. This was a good icebreaker to play some music and get kind of acclimated to this online business. This is our 11th, right? Our 11th live Q&A. So I've been on 11 months in a row. Every second Tuesday of the month, I come on and answer any questions you may have. And we leave it also open to anyone who comes live. Hello, everyone. Karina, that has questions. They come live and ask those questions. At this point, anyone who submitted their questions before, we'll try to get to those. If anyone is online, they submit questions. I try to get those answered as well. So we're kind of play it by ear. For now, we've got a bunch of questions already lined up, and we're going to go from there. So, am I starting from the list here?
Yes, sir.
Okay. So let's see, right here. All right. So tell you a little bit about myself. Some of you guys, that's maybe your first time here. I'm a foot and ankle surgeon located in Los Angeles, California. I've been in practice since 2008. So that makes it 20, no, I'm sorry, 13 years. 13 years I've been practicing. And it's been a blessing. I love what I do. I absolutely, absolutely love what I do. And I look forward to go to work, and I always look forward to help patients and innovate procedures so it can help my patients and their progress and their healing time. I'm always looking for better ways. So I have developed my own advanced minimally invasive bunion procedure called the Amy Bunionectomy. So advanced minimally invasive bunionectomy. And I have a trademark on that name, not the procedure. Anyone can do the procedure. I'm actually very open to teach that to any surgeons around the world who want to do it my way. Um, Also, I do a brachymetatarsia surgery, which is a metatarsal lengthening. Patients who have a short metatarsal, which in turn turn their toe shorter, I lengthen those, whether using an external fixation or a bone graft from their own body or from a cadaver. So I do all of those. I have developed my own techniques of doing them, so it's more successful. Obviously, everything that's related to foot and ankle surgery I do, but those are the two most common surgeries that I do in my clinic and my own surgery center. I have my own surgery center. Cutting Edge Surgical Institute is my own surgery center, and I operate there 99.9% of the time. Here and there, I go to the hospital, but everything is there. I have set it up exactly the way I want to do it, and that's why I operate there. So that's an introduction of what I do. I have also published a paper on the minimally invasive bunion procedure 4 years ago in the Journal of Podiatric Medical, no, Journal of American Foot and Ankle Surgeon. So those, JFAS, sorry. Those are kind of my credentials. I lecture around the country as well. So if you have any questions, please come on and ask those questions. Today, we're going to kind of start going and answering questions that have been submitted to us. And I'll be looking to my left. Hi, everybody. And answer any questions that they may have on Instagram, which is a different platform. We couldn't get it all in the same platform. So on my left would be Instagram. On my right would be YouTube and Facebook, right? Correct. Yeah. So here we go. Our first questions is, what is the level of pain from brachymetatarsia surgery reported from your patients? Very good question. So again, there's two ways that I operate. Brachymetatarsia done using an external fixation. The second method that I use is the bone grafting method. So they're completely two different procedures with the same results. Pain-wise, it seems like the external fixation has less pain at the beginning, because all I do is install the device on your foot, under the metatarsal, and cut the bone. Everything is done percutaneously, meaning through the skin. I don't open anything. A small incision on the side of the bone is cut with an osteotome, which is a small chisel, and then we're done. The surgery is done, and then the patient starts doing adjustments at home. So it seems like the patients who have the external fixation, they have less pain at the beginning. When it gets towards the end, they start having more pain. Is it unbearable? No, because the adjustments are about 0.5 millimeter a day. So it's not huge adjustments that you feel it. But as we're extending, when we get towards the end of the lengthening, like we're at 1.9 centimeter, that's when, you have more discomfort. Even though I let my patients walk from the second week on with their external fixation. When I do the bone grafting, it seems like the pain is a little more at the beginning because the incision is bigger, because I have to insert a bone graft and distract the bone, cut the bone, distract it, put a bone graft, put plates and screws, and then close everything. So it's a more involved surgery, a more invasive surgery. But so more pain and more swelling at the beginning, but then as times goes by, like the second, third week, the pain subsides. So they both have their advantages. One heals faster, the other one takes a little longer, um, and then the results very similar in my hand actually at this point, because I have configured this procedure, this the bone grafting. I have added some additional or ancillary procedure that goes along with the bone grafting that has made it successful. I feel like up to 1 centimeter, it was good. But then passing 1 centimeter, like if you have shortening that was more than 1 centimeter, it was becoming more complicated because the joint jamming and also the tendon issues and a whole arrays of issues that would come up, which I have addressed every single one of them now. Have had some complications, had to come back to the drawing board and see what we can do to improve it. So I've done all this. So now I do a tendon lengthening. I insert a spacer in the joint, so that way when I'm extending the metatarsal, the joint is not jamming, as well as releasing some of the ligaments around the joint. Also keeping a K-wire inside the toe and in the metatarsal with this spacer, kind of shish kebabbing the spacer in the joint. So a lot of ancillary procedures that I do with the bone grafting that has made it more successful now. Also trying to control the swelling after surgery. Compression for the first 2 weeks is very important. That's something that I wasn't doing at the beginning, to keep the incision closed or to keep the incision calm, because if the incision has a lot of stress on it, you get a big scar. So all these things had to be modified. So hi everybody who's logging in. Please, if you have any questions, go ahead and send it our ways. But can I walk? Okay, so one of our patients asking, can I walk normally direct after surgery? Are we talking about breaking metatarsia? I'm assuming yes, because that's what we're talking about right now. So both procedures, the first 2 weeks, I tell my patients not to put weight on it as much. And then after the second week, you on both procedures, the bone grafting and the external fixation, you can start putting weight on it. And you start slow, meaning putting 50% weight, and then you start increasing. So yes, within a couple of weeks, you can put weight on it. All right, so next question that was submitted through the email. Would you say the cause of breaking metatarsia is due to chromosome disorders? So I don't know. I mean, it could be. It's a genetic disorder for sure. Do we know exactly why? No. There are times that it can skip a generation or two, and there are times that it could just completely be a mutation. I've had patients that they said they have not had anyone in their family, all the way going back to their great grandparents. As far as they know, nobody had it. So we don't know. And honestly, I know it's not, it's okay. To me, it doesn't matter. Like if I had it, it wouldn't matter why I got it. But I could understand the question, because you want to know if your kids will have them or not. That's usually the question that patients are asking. And unfortunately, we don't know. And you're not even born with it. Usually around the age of 6 to 8 is when you start seeing the change. You start seeing the fourth metatarsal is not growing as fast as the other ones. It's not keeping up with the other metatarsals. And that's when we notice. So it's not even something that's present at birth that we can, put our finger on it. So yeah, I wish I had that answer, but we don't. And I wouldn't worry about it, because the procedures that we're doing right now, the treatments are very successful. So that should be the least of your worries.
So Derek,
Any tips for a DPM school interview? Okay, so this is a good one. Do I have any tips for DPM school interview? So this gentleman wants to apply probably for podiatric medical school and want to know if there's any tips. I think as long as you do well in your MCAT and your overall GPA, you shouldn't have maybe some extracurricular activities such as like volunteering in hospitals, and maybe I think podiatry schools, they pay attention to if you really want to know if you want to be a foot doctor. So it would be helpful if you can shadow or volunteer at another foot doctor's office or foot and ankle orthopedic office to show that this is what you've done your research and you're very interested in. I think that would help. So hopefully that helps you. So after Amy heals, can you run? Okay, so thank you for that question. So they're talking about my Amy procedure, advanced minimally invasive bunion procedure. Yes, after that bunion procedure or bunion surgery, after the bone heals, you absolutely going back to normal. Once the bone heals, you're back to normal. You can run, you can wear high heels, which is very important to you guys, females. And you can basically jog, run, cycle, yoga, anything you want to do. The bone, it's almost like having a fracture. Once the fracture heals, you can go back to normal. So the bunion surgery is the same thing. We are fracturing the bone. The surgeon is fracturing the bone to put it in a better place, and then it's waiting for it to heal. So once it heals, you're back to normal. And just like any other old fracture that it heals, like your wrist fracture, once it heals, you're back to normal. If it's done right, if it's positioned in the proper place. So yes, you're back to normal. Okay, so very good. Thanks for those questions. So we're gonna move to our.
Flora says hi to you.
Oh, hi. How are you guys doing? Thanks for logging in. I appreciate it. All right. So next question: do you take insurances? So this is also another question that we always get, and unfortunately, I don't talk about administrative stuff online because this is just a Q&A about symptoms. I'm trying to be a doctor right now. I don't want to talk about business, but we do take insurance. So to answer, to be straightforward, we do take insurance, and if we don't take your insurance, then we can offer you out-of-pocket expense or cash price. But yes, we do. What was it that you were trying to tell me?
Another question as well, but you probably.
Okay.
Same follower. Can you make a surgery to fix flat foot?
Okay, yeah, very good question. So flat foot surgery is very interesting. It's actually one of my favorite surgeries to do, but it's also one of the most complicated surgeries to do. So, same as cavus foot, meaning high arch foot or severe flat foot. I only recommend it when the patients have a lot of symptoms. So if you're, for example, my own brother is flat-footed, but he's not complaining. He doesn't have any issues. He plays soccer. He's never had any issues or pain because he's just flat-footed. He doesn't have a normal arch. But if you are a severely flat-footed person to a point that your foot is turned in, your ankle is coming in, and you're kind of collapsing, and you're putting stress in your other joints, such as your ankle and knee and hip, then yes, you definitely need to have flat foot reconstruction. That's what we call it. Same as cavus foot. If you have a high arch, not a big deal. But if you're symptomatic to a point that your foot kind of looks like a tripod, and you're putting a lot of stress on your heel, on your fifth metatarsal, your first metatarsal, and you're constantly in pain, and you have bad hammertoes, that cavus foot needs to be treated. Otherwise, you're going to have a lot of pain. You're going to have a lot of subsequent deferred pain or subsequent condition that can come with it. Adjacent joints can be affected after a while. So that's just in general talking about flat foot and cavus foot. Do I do flat foot reconstruction? Yes, absolutely. Is it an easy procedure to do? No. Is it an easy recovery? Absolutely not. So basically, bones have to be broken, and I'm sorry I'm putting it that way, but your heel bone sometimes in one area or two areas has to be broken to put either a wedge into the bone or extend it, or the area that the Achilles tendon is attached has to be cut in this area and move down sometimes or move to the side. So every flat foot is slightly different. What I usually do, I put my patients on a standing CT scan where you stand and you get a CT scan of your foot and ankle, and I see where the bones are laying on top of each other. How is it laying on top of each other? And what's the pathology exactly? And then I'll plan my procedure there. There are times that we have to extend tendons. Sometimes we have to tighten tendons. So a lot of procedures in flat foot. It's not just one procedure. It's just basically kind of going around the foot and addressing every single position that's not optimum. But it's a successful surgery, but like any other surgery, it has some complications, 5 to 10% complication that can come with it. But that's why I only offer it to patients who are very symptomatic. When they have a lot of symptoms being flat-footed, I definitely recommend flat foot reconstruction. For children under the age of 15, 14, there are some implants that been around for a while. We call them MBA implants. They go into your subtalar joint, and it kind of holds the subtalar joint open in a certain position, so that way it reduces the mobility of that joint, because sometimes they're hypermobile in that joint, which is the subtalar joint. It's this joint right in this area. So that corrects the children's flat foot, and we keep them in there for a few years till they're kind of in the adolescent age and maybe fully grown, and then we can take them out, or we can leave them in there if they're not bothering them. So it's a big topic. Flat foot is a big topic, but yes, there are procedures that can be done for them. All right, next question. I love the fact that everyone is using Amy Bunyan procedure. Finally, my procedure, everyone is referring to it, which I love it, because that way you can kind of identify one procedure from another. That was my whole point of getting a trademark, because everybody now has a minimally invasive procedure. Every foot doctor or foot surgeon, foot and ankle orthopedist, like you call them, do you do a minimally invasive bunion procedure? They're gonna say yes, but what kind? And they could be making their incision from this big to this big, and they call it minimally invasive. So that's why I kind of wanted to name it and separate it, so that way we can kind of address, when I'm talking, that we can talk about that procedure. That's the whole point. But yeah, thank you for mentioning that name. How long do I need to take off for Amy Bunyan? When will I be able to walk fully normal? So, okay, good question again. You're walking the next day. Everyone has a different pain threshold. I always tell my patients, I'm going to be, very straightforward with them. There are patients that, most of my patients, I want to say actually 80% of them, they have very little pain. They don't even take their pain medication. But there are patients that I have had that have moderate to severe pain, because their pain threshold is very low, and it has nothing to do with them. It's just the way their body reacts to pain or to bone pain. Maybe they've had other surgeries and they were fine, but now. So I always tell my patients, I can't tell you exactly how much pain you'll have or discomfort, but I know it's at least 50 to 60% less than a traditional bunion surgery, or less than Lapiplasty or Lapidus procedure, because those are very invasive procedures. Whenever you open the skin and dissect soft tissue, you're going to have more pain and you're going to have more swelling. That's a fact. No one can change that. I don't care who comes and tells you that's going to be less. Bunionplasty or Lapiplasty has less pain. That's not accurate, because whenever you make your incision this big, you're bound to have more pain and swelling. You ask any surgeons, they're going to tell you that. So the fact that incisions are so small, like my incisions take one stitch to close, and I make 3 of them, one here, and one here. So 3 small incisions, and I operate through those incisions. So I don't disrupt any tissue, muscles, or ligaments. So I go in, cut the bone, reposition it, put my screws percutaneously through the skin, and then I'm out. I'm done. It takes me 15 minutes to do my procedure. So, and then the bone healing starts. Any bone that's fractured or broken, or we cut as surgeons, we create a surgical fracture. It takes about 8 to 10 weeks to heal. Doesn't matter who does it, who cuts it, who breaks it. 8 to 10 weeks. But the difference between week 1 and week 10 is what matters. Are you going to have pain? Are you going to have instability? Are you going to be able to walk on it or not? That's the difference between Amy bunionectomy and a traditional bunionectomy. That's the difference between Amy bunionectomy and Lapiplasty or Lapidus procedure, or any other chevron procedures or bunionectomies. So 8 to 10 weeks for it to heal. Are you able to walk? Yes. Are you able to drive? After week 3 or 4, I'll let you drive, not because you can't drive, but because of medical legal purposes. You know, you have to be safe on the street. So yeah, 8 to 10 weeks it takes, but you're walking, you're doing your things. And if you have a desk job, you can go back to work after 2 weeks. I've operated on ER physicians who went back to work after the second week. She had a scooter, and she said, if I need to, I'll use my scooter. She had a knee scooter, and she was getting around from one room to another. But if you have a demanding job that you're on your feet, such as a flight attendant, let's say, because I've operated on a bunch of them, cashiers, people who are on their feet all the time, UPS drivers, things like that, then you need your 2 months to fully heal. Because nurses, a bunch of nurses I've operated on, and they have shifts, that 12-hour shifts that they have to be on their feet. So they most likely take their 2 months off so they can heal. And that's not just with me, with any bunion surgery. As a matter of fact, with traditional bunion surgery, it might take twice as long for them to be able to go back. That's what I used to see. All right, so hopefully that answered that question. How long do you have, or how long have you been in practice? Success rate of Amy Bunyan procedure. Very good question. I already said how long I've been in practice, so 13 years. How long have I been doing Amy bunionectomy? 7 years, going on 8. Was it the same procedure today than it was 8 years ago? Absolutely not. It was a completely different procedure. The pins were going in different directions. It was only one pin. There was no screws. It evolved over the years. I had to listen to my patient, see my results, change things. Listen to my patient, see my results, modify things. All that. But for the past 2.5, 3 years, I haven't changed anything because everything has been working perfectly. So I haven't really had to change anything. So everything is working the way it should. So there was no need for modification. But the success of the Amy procedure, is the same as the success of any other procedure, meaning any other bunionectomy, because this is not just shaving the bone. Some patients think that Amy bunionectomy, because the incisions are so small, you just go in and shave the bump. No, this is a full-on bunion procedure, cutting the bone, repositioning it, translating the bone, realigning everything. It's a full-on bunion procedure. And if someone tells you that it's not, they're not giving you the right information. So you should come and ask me. It's a full-on procedure, and it lasts as long as a traditional bunion surgery. In my knowledge, no one has ever followed 200 patients for 20 years to see when their bunions came back. I don't know any studies like that. But if someone ever did it, then we would know what's the rate of bunions to return, or recurrence rate. Then again, it's also operative dependent, meaning if a surgeon fixed a bunion and it did not fix it properly and undercorrected it, that bunion may come back in 5 years. But maybe if someone else did it and did a great job and realigned everything and it got everything corrected, then maybe that bunion would have lasted 15 to 20 years. So it's very different how someone does a procedure versus another surgeon. I've had patients in my office that had bunionectomy 3 years ago, and the bunions are back. Either it was just shaved, or they undercorrected it, or they were not corrected properly at all. So tendon rebalancing, repositioning the bunion, repositioning the bone, cutting the bone, all that stuff makes a difference. But the success of the Amy Bunyan procedure is as the same as the success of any good bunion procedure that we've been doing for more than 70, 80 years. Nothing less. As a matter of fact, you can fix severe bunions with any bunionectomy. Like, I haven't had to do a lapidus procedure, which is now known as lapiplasty, for the past 7 years. Even my most severe bunions, I've been able to fix it with my Amy Bunyan procedure. That's how powerful this procedure is. So no need for lapiplasty, no need to fuse your joint at the base, because that's what lapiplasty is. They basically cut this segment of the bone from your foot out. This bone becomes shorter, and they put 2 or 3 plates here with about 10 or 11 screws. And it's been very popular lately because they've been just advertising it on social media. So the success of Amy bunionectomy, it's very good in my hand, at least. Can I have 2 feet surgeries at the same time? Of course. I used to do bilateral. That's what we call a bilateral bunionectomy, or even metatarsal lengthening. I still do here and there. I just don't prefer doing them. That's just me. I feel like patients don't do well when you operate on both feet. I believe in the whole body healing experience, meaning if your both feet have been operated on, you're most likely going to sit on the couch, you're most likely going to lay in bed, and you're not going to do much. So I believe in you being able to go around, still go to dinner, still be able to get around, still go outside, get some sunlight. I feel like you heal better, and you're not as depressed, I want to say, sitting home for 6 weeks. But there are times that I have patients that came from China, Saudi Arabia, that they said, hey, I'm here for 4 weeks and I need to get both of them done. So there are exceptions. For me, it's easy to do. I just another 20 minutes and I can do another bunion. It doesn't matter to me. But I always feel like I have to do the right thing for my patients. If it's possible for them to do them separately, I prefer it that way. That's just me. I think about the patients and their recovery, because you can't just be a mechanic. That foot is attached to a body and it's attached to a brain. So you can't just go in and look at it as a car. I'm just going to fix this and fix this and fix. You have to think about the recovery. How is this patient going to get around? How is this patient is going to be able to go to the bathroom? How is this patient is going to, all that stuff, even though you can walk on my procedure, but still you're going to have pain on both feet. You're going to be you're going to be uncomfortable. You're going to have discomfort. When you have one foot operated on, you put most of the pressure on the other foot and get around very easily. So that's just me. But anyways, but thanks for that question. This is a very good question. So let's see. So I'm going up now, right?
Yes.
All right. Next question. All right, another administrative question. How much does it cost to get brachial metatarsia surgery for both feet? Again, I don't talk about the administrative stuff here, scheduling, when is my next opening, how much does it cost, any of that stuff. That's just something I don't do on my live session. But we have a patient care coordinator who's more than happy to get all your information and get back to you within 24 to 48 hours, where I have a dedicated patient care coordinator who all she does day in, day out is to talk to future patients that are having questions, such as this gentleman. So please contact us at patient care. Did you put that on the patient care at fixmyfoot.com? So that way, she can get back to you. She'll have to get some information from you to see what exactly the procedure you're looking for, and then she'll get back to you as soon as possible. I'm not sure if it was a gentleman or a female. I'm sorry because sometimes the nicknames don't tell me exactly what the gender is. So next question again is average cost for each procedure, please. Again, I'm gonna refer that to my patient care coordinator. Please ask her and she'll get back to you best way she can. All right. So next question. Tort shortening. Very good. Tort shortening and nerve damage. So I don't know um, what this patient means. Does that mean when you have tore shortening, is it possible to get a nerve damage? You think
Yeah.
that's what that means?
Yeah.
Okay. So because she wrote tore shortening and then nerve damage question mark. Um, Actually, tore shortening is pretty safe, I want to say. Tore lengthening might cause you a little bit of nerve stretching because when you stretch something, it becomes a little thinner. So nerves, arteries, vessels become a little thinner. So not that they become permanently damaged, but there would be definitely less circulation and less signal going through for a short period of time when we stretch the nerves. But as far as nerve damage, tore shortening is pretty safe. Again, I would have to know exactly what area we're talking about. Most of the toe shortening I have done are basically on the second toe because those are the ones that most of the patients having issues with. The second toe is longer. So if we're talking about the second toe, there's 3 bones in the second toe. Let's go over a little bit of anatomy. So proximal phalanx, middle phalanx, and distal phalanx. There's 3 bones. So usually I take an x-ray and I see where we're supposed to take the bone from. If you have an excessively long segment of the bone in here, then this is the one that I make short. If it's the middle part that's too long, then we'll take bone from this. Very rarely I take bone from this part, the distal part, the last part. So either from the middle part or the first part. And then you will have to insert a screw to hold the bone segment in place so that way the bone heals. So we'll take a piece of bone out. There will be some loose skin on the side of the toe. So basically it would be kind of like a I don't know, like love handles. Let's put it that way. So you take a little bone out and you squeeze everything. You have a little extra skin around, which gets absorbed, and your toe basically adapts to it. But other than that, besides that, I haven't really seen anything. I've had patients who've had complications. I've had a patient who broke her toe after a toe shortening procedure, and all the other complications that came after it, infections and all that stuff. But if there are no complications, it's a very safe procedure, and it's done. It's done quite often in my practice. Actually, a lot of ladies want to get their second toe shortened, and it's so interesting because we were just talking about it the other day. There are patients who come and they have a long second toe and they want to make it shorter, and then the week after, I get a patient who has a short second toe and she wants to get it longer. It's just, I never know what someone wants. Obviously, in a safe environment, I can operate on both of those patients and give them the results they want. But it's like plastic surgery. I'm not afraid of any judgments because plastic surgery has been around, and patients want to have a certain look. Some patients want to be taller. When I was in my fellowship, we would do statue lengthening the femur and the tibia. For a male that wanted to be taller, we could add 2 inches to their height. And people can't be judgmental because we have, everyone who wants to have something, breast implants. Some women want to have a smaller waist or whatever, smaller nose, higher cheekbones. So this is the same thing. Some women don't want to have a long second digit, or they want to have it shorter, or whatnot. So I'm not there to judge them. I'm just there to safely perform the surgery that they're asking me to do, looking at their medical records and see if it's safe for me to perform that procedure, and making sure that they know what they want. So anyways, toe shortening, it's very, very popular in my office. I get them all the time. So hopefully I answered this lady's question, and thanks for that question, by the way.
Yeah. there's also a question, I think, on Restream, the chat. I noticed one.
Do you know how COVID vaccine work? Okay. All right. So this is a random question from I don't know who, but we're not talking about COVID vaccine right now. But so I'm not going to get into it. I have read a lot. I know a lot, but we're not going to get into COVID vaccination right now. But I have been vaccinated. I haven't had my booster yet, but I've been vaccinated. Next question. All right. So next question is talking about breaking metatarsia. Okay. So can breaking metatarsia be on one foot? Yes. It's a good question. Yeah. I mean, there are times that I see breaking metatarsia on one foot only. There are times that I see it on both feet, on the same toe, meaning fourth toe bilateral, both feet. And there are times that I see it on, like today, I'm going to be operating on a patient who has a breaking metatarsia on the right, fourth, on the left, third. And I've had it where it's on like second and third on the left and second and fourth on the right. It's just, you never know what you get. But for the most part, the most common area would be the fourth metatarsal, and either one foot or both feet, but the most common is fourth. And females mostly affected versus males. We still don't know if that is a true number because we can only go by what people report. So if there's 200 men and 200 women that have brachymetatarsia, and the 200 men are not coming forward to tell us that they have brachymetatarsia because they don't care, because they wear shoes and they really don't care, then we would think that out of these 400 people, only 200 of them have brachymetatarsia, and they're all women, because that's what it's been reported. So that's the thing. Most of the reported brachymetatarsias are women. Is it because it's more prevalent, or is it because this is what the report we got? I don't know. So it seems like that it's more common amongst women. I think I've seen some articles where they've dug in more and they kind of figured out that it's more genetically related to women. But again, I've treated men as well, but not nearly as much as women in my practice, at least. Same as bunion. I operate on maybe 20 women and then one man as far as bunion. So again, yeah, it's one of those things we don't know exactly the number, but that's what's been reported to us. All right, so far so good. These are the questions on this side.
Yeah.
Are there any more besides these?
I believe that would be it.
That would be it. Okay. So I think we got to all the questions that it was submitted to us. Today we also wanted to kind of go over the different devices that are available to us for breaking metatarsia or metatarsal lengthening. So sometimes I have my patients ask me, like, why do I see so many different devices on patients' feet? Because different doctors operate on these patients, and everyone has their preferred device that they use. I've, in my practice, used pretty much all of them so far. Every single one of them that's been out, I've tried it, because I'm always still looking for the perfect one, because there has not been a perfect one yet. The trick is that the orthopedic companies that make these devices, they make them for multiple purposes. It's not just made for breaking metatarsia. Why? Because breaking metatarsia is not that common. It's not like hip arthritis that you go and say, like, I want to make a hip implant and it's just going to be for the hip, because there's so many of them. Like every hospital does hundreds of hip replacements a month. So it's more common, but brachial metatarsus is not that common. So for an orthopedic company to come and invest the research and development for years and get patents and FDA clearance and all that stuff for use for one condition, it's not profitable to them. So no one has ever made, in my knowledge, a device that's specifically made for brachial metatarsia. So these devices that we see can work for any kind of a fracture in your hand, in your foot, because this device can compress and also extend. So they make them multi-purpose. It makes sense. So that way they can use them for different purposes. So there is not a perfect device yet that was made for brachial metatarsia. The ones that I've used have been from EBI, Wright Medical, Vilex, MDI. I mean, I've used them all. Zimmer. Lately, I kind of like the Zimmer Biomet one, and I like the Vilex. That one is good, and the MDI is good too. So those are my top three that I've been using. To me, a device that's very stable is the best device and easy to use for patients, because the patients have to do their adjustments at home. So it has to be easy for them to use as well. So those have been my top three, and they're all good. The only advice I can give you, if you're not my patient and you're going somewhere else, make sure once the device is installed, there are 2 pins that goes into your fourth toe, because you want to, when you're extending your bone, you want the fourth toe to go along with the metatarsal. If the fourth toe is not going with the metatarsal and you're only extending the metatarsal, that joint, the fourth metatarsal phalangeal joint, is going to get jammed, because you're just pushing the metatarsal out and the toe is there. And all the tendons and ligaments are holding it back, and you're pushing the metatarsal and you're just kind of jamming the joint. So that fourth digit, your fourth toe, has to be included into the fixator, this rail fixator that we use, so it can extend everything. So that way, when we take the device off, when the bone has healed, you don't have jamming of the joint. So you have preserved the range of motion or the space in that joint. So that way you don't have issues with your range of motion. When you do bone grafting, I have been putting a joint spacer in there that I have made myself from suture material, which I take out later once everything is healed. So that kind of acts like a device that kind of pulls the joint or gives me the joint space that I need. So those are the questions that have been coming up in the previous sessions that we had, and I was never able to answer, and we ran out of time. So I addressed it today, and so I think if we're not doing anything, if there's no questions, I thank everyone who has logged in. I appreciate every single one of you. We are obviously going live every second Tuesday of the month. So if you couldn't get in, we have this session recorded. We're going to post it in a few weeks on YouTube and Instagram. So watch that. My website is 877-foot911 or just fixmyfoot.com. Both of those goes to the same place. It goes to Khosroabadi Institute. And if you we have email, our email is listed there, and also there's forms there that you can fill out, and someone will get back to you within 24 to 48 hours. We're very good with that. I look forward to get your questions. I look forward to meeting you here if you're having surgery with me. I know some of you have come through these live sessions and have turned into my patients. It's great that I see patients that come and have come from our social media. I actually have a patient tomorrow, and she's looking forward to get the happy face, which is one of my trademarks that I put on the patient's toes after bunion surgery and after brachial metatarsia surgery. So they're actually looking forward to get the happy face, which is great. I mean, nowadays the the era of social media it's allowing doctors to connect to patients directly without having another doctor to be involved. Like it used to be like you have to go to your internist and then they have to refer you to me. But now patients are searching for the answer themselves, and they find the answers and they talk to the doctor and they see results, and so we're all kind of in this space together, social media, and we meet each other. So I look forward to meeting you guys in person if you're coming to us. If you have any questions for anyone else, I don't mind. Just come on live next time or send your questions to us. We'll answer them. Good luck to everyone. I'm here to serve my patients and innovate new ideas, new surgical techniques to make things better. And again, thank you, Sako, for arranging for this. We've been doing this 11 months together. Thank you. It's been successful, and we're going to keep doing it. Please follow me on Instagram, TikTok. We've been huge on TikTok lately. We're making a lot of videos. So follow us there, and I'll see you next month, second Tuesday of the month. Thanks again. Have a good day.